Long story, when I was 11, I went to see a hospital in its initial stages. And I remember going up on the escalator with the guide, and he looked at me and he said, you know, this is an 11-year-old, what are you doing here going around a newly built hospital? What are you interested in? I said, food. I love food, and I think I want to work in a hospital, and I want something to do with food. He said, oh, you want to be a dietitian then? I've never heard of a dietitian, but it sounded a good idea at the time.
I'm a senior dietitian at the Middlesex Hospital in London. My speciality is oncology, looking after the patients on the oncology wards. Patients on the oncology wards have all sorts of problems, ranging from simple problems like they haven't got their teeth, they've come into hospital without their teeth, or they've lost so much weight that their teeth don't fit, right through to taste abnormalities and taste changes, which are a common occurrence with cancer. Basically, what I do is talk to most of the patients on the ward. Up to 80 to 90% of the patients on these wards are on some sort of special diet. Talk to them about their particular eating problems and try and find the answer to their problems. Throughout the hospital, but particularly on the oncology wards, we rely quite heavily on the nursing staff. Firstly, to identify patients that do have nutritional problems and eating problems, and then refer them on to the dietitian. Secondly, to ensure that any special diets that we prescribe or any supplementary drinks that we prescribe are actually delivered to the patient and taken by the patient. And then lastly, for feedback as to how the patients are managing, whether they're enjoying their supplements, how they're managing with the food. So we do rely quite heavily on the nursing staff. Anorexia, which is lack of appetite, is a very common problem with patients on this ward, and up to 70% of the patients at any one time have this sort of problem. It can be caused by depression, anxiety, or the anorexia can be caused by the disease itself, and there is a theory that certain tumours can produce toxic hormones which may then affect the neuroreceptors in the brain, causing reduced appetite.
In hospitals, specialist dietitians are needed in many areas.
The burns ward consists of about 20 beds, and my responsibility there really is to look after patients who have had quite severe burns. We recently had most of the patients who came from the King's Cross fire. Most of the work really involves tube feeding patients, so we try to ensure that they get adequate nutrition, and this is done by sort of regular monitoring and also ensuring that we feed back, obviously, to the doctors and nurses, mainly by ward rounds.
Which is the original one?
The original one.
Come on to the perineum on the side of the scrotum. Great. So he's really done very well.
He's doing very well. He's feeding up.
How are we from the feeding point of view?
Well, he's having a litre of feed overnight, and he is supposed to be trying to eat as well.
So what's he getting in calories then?
He's getting 1,000 calories from the feed, and then he's getting approximately 1,500, but it's mainly from drinks, and we're trying to encourage him to eat. So he still needs the tube feed, doesn't he, really? The dietitian needs to ensure that the correct amount is being delivered to the patient, so therefore we have to work out what the nutrition requirements of the patient are, and from that basis we have to decide on the type of tube feed that is necessary for the patient, because different patients have different needs, and I think, in my opinion, the dietitian is the only person who's suitably qualified to provide that information, and also to monitor the patient afterwards to ensure that they are receiving what they're supposed to be having, and that the patient is actually improving nutritionally.
Increasingly, dietitians are now community-based.
Hello, Jackie, I've got a problem. Can I just ask your advice?
Sure, come and take a seat.
Lovely, great. I've got a client, I saw in clinic yesterday, and her toddler's got a feeding problem. Basically, she's refusing dairy products, and it's been since the new baby's been born, and mother's getting a bit worried. The child was never a very wonderful eater, but now she's really refusing most of her dairy products.
How old's the child?
23 months.
And what's her present weight?
Right, she's about 10.3 kilos at the moment. I'll just show you her centile chart here that I brought along with me. Just thought you'd like to see it.
So she's growing quite nicely along the 50th percentile, so we've not had any drop in
That's right.
in her length.
She's been fine on that. It's just been
I'm
her
community
weight.
dietitian for Barnet Health Authority, and a lot of my work is actually working with other professionals because there is only one of me, and in most health authorities they actually only have one community dietitian. They either ring me up or they pop into my office, or I will actually go out in groups and speak to health visitors or district nurses, practice nurses. I also go along to GP practices. I don't think anybody can do without a community dietitian.
Lovely, great. Thanks, Jackie.
If you've got any further problems,
I'll pop in and yes,
or
I'll
give
give
me
you a ring. That's lovely, great. Thanks very much, Jackie. That's lovely.
The major current area of expansion is into working with the general public. So there are a lot more dietitians moving into community work and also the elderly. And I think this may even mean that in the not too far distant future we may see dietitians working for local authority social services.
Well, certainly the elderly population are increasing, and they're definitely the biggest users of the health service. Elderly people are also considered to be nutritionally at risk. This can be for a number of reasons. For instance, social isolation. If people live on the 9th or 10th floor of a block of flats, they might be frightened to go out. They might have physical problems in actually using public transport or carrying their shopping. And all of those problems can result in people having a decreased food intake.
But what can the dietitian offer young people?
We've actually looked at our school meals in Brent and are now actually providing healthy meals for our children. We looked at the evidence really of what our children were eating in school, and we felt that our children really weren't eating a healthy diet. National surveys have shown that children are eating far too much fat and too much sugar, salt, and not enough fibre. Brent's quite unique in that we have a very large culturally diverse population, and we've tried to ensure that our meals reflect that. To start with, we had some initial resistance, as to be expected. Everybody's a little suspicious of change, and the children perhaps were a little reluctant to try some of the new dishes. But with persuasion from the school meal staff and a lot of help from the teachers and lunchtime supervisors, the children were soon making good choices of foods.
As a community dietitian, my main job is prevention. So I see healthy people, and most of the time is spent advising, giving lectures. As I said, the aim is prevention.
Yeah, I was wondering, which ethnic diet are we specifically talking about? Is it multicultural?
We're not really talking about any ethnic diet. In a multiracial and multicultural Britain, there are so many ethnic groups present. So at the moment, we are talking about Chinese diets, Greek, Turkish, Jewish, Scottish, Welsh, Indian, Pakistanis, West Indian or Afro-Caribbean. So those are the diets we are talking of at the moment.
When I was a student like you, celiac disease was almost exclusively a condition of children.
Specialist dietary advice can be critical for some.
And last year, Celiac Society statistics showed that for the first time, over 80% of our new members were adults, and only 20%, therefore, were children. So it can happen at any time. So I'm the consultant dietitian for the Celiac Society of the United Kingdom, which means I am a qualified dietitian, and I actually work for them. They pay me. It's a patient's self-help group, and most of the people who work for the society are actually volunteers, but I'm what I call the paid help. There are several dietitians like myself working for similar organisations, the Dietetic organisation, the phenylketonuria organisation, and we just do very different things to hospital dietitians. You never know, because we now actually think that once you're a celiac, you're a celiac for life, and you know, it is a diet for life.
Nutrition interests most of us, but why does someone become a dietitian?
When I was about 7, I wanted to be a farmer. By the time I was about 12, I decided I was more interested in people than animals because they talked. And I'm very interested in nutrition. I always enjoyed nutrition when I was at school. And so I decided I wanted to be a dietitian because both my nutrition teachers were dietitians originally.
I think a lot of the students have a basic interest in nutrition. They also have an interest in medicine, and they like people. And they generally are students who are highly motivated to helping people.
there are many ways of actually becoming a dietitian. You can in fact take a degree in nutrition and then go on to do a postgraduate course. You can also arrive at being a dietitian by doing an undergraduate course in biochemistry or physiology, and then a postgraduate course in dietetics, which is a 2-year course, which we do run at Leeds. Or you can do a 4-year undergraduate course, and the predominant subjects that you actually study as an undergraduate are biochemistry, physiology, nutrition, food science, microbiology, social studies areas, because dietitians have to be able to communicate, talk to people and understand what motivates them. And have I mentioned nutrition? Because nutrition, of course, comes into all that.
What students are taught is based on scientific research.
We are studying the physiology of energy balance. This actually is the key equation for our research. We're looking at the energy that goes in, the calories that go in, which of course is diet, and the energy which goes out, which we call total energy expenditure. If you look at this diagram here, if that column represents total energy expenditure, we measure total energy expenditure using the doubly labelled water method, that is using deuterium and oxygen 18. The basal metabolic rate is about 2/3 of one energy expenditure, and we measure that using indirect calorimetry, bringing people into a calorimeter overnight and measuring their basal metabolic rate between 8 o'clock and 9 o'clock in the morning.
I work with a group which is primarily concerned with gastroenterology, and we were set up originally to look at the suggestion that people living in countries such as Britain were eating a diet which is deficient in dietary fibre. Nowadays we have these new technologies which allow us to do this, and sometime this morning Richard has swallowed this capsule here. The radio transmissions picked up by the aerial that Richard's wearing, and they're then fed into this recorder. We will also be doing lots of other investigations as well, including bacteriology. Richard, for example, has been producing breath specimens over the weekend. He blows into a party blower, and we can look at, say, methane production. At the moment, Richard's on a high-fibre diet. Well, he's on a high-fibre, high-starch diet, which means Richard being on the same diet for a month. We then swap over, and he then goes on to a low-fibre diet, and we'll see whether pH goes up as a result of the low-fibre diet, because we're not feeding the bugs with sufficient carbohydrate for their fermentation.
The dietitian is the link between the science of nutrition, the biochemistry, the medicine, the knowledge of food, food science, specialist foods, the link between those two areas and what people actually do. Sport is one area where we're just beginning to get a toehold, and I think there will be more dietitians actively working with sports people in the future.
The requirements of athletes is very different from sedentary people. For example, somebody who is a long-distance runner will be using their carbohydrate stores very, very quickly, and therefore it's very important that they refuel these stores, and therefore the diet that they should be following is a high carbohydrate diet that is low in fat as well. Women athletes do have a slightly different requirements. Probably the most important is their iron requirements. Certainly many women are very health conscious nowadays and maybe keeping off red meats, and therefore their iron intake is likely to be low. And therefore with some women athletes it's important to do maybe a detailed dietary analysis to be able to assess whether they are taking in enough iron.
In the London Borough of Hackney, dietitians researched how many times people ate out and what they ate. Eating habits were not always very healthy, so the dietitians decided to encourage better food choices in restaurants. How did they do it?
What we did was we had a competition which we encouraged any place, if they had healthy food choices on the menu, then they could win an award. And today we're in a restaurant which actually won the top prize in the Restaurant Wine Bar Award. And some of the foods are here on the table. I can show you one choice they provide is wholemeal bread as well as white bread. The other thing is the vegetables are cooked very well to maintain the vitamins, and also jacket potatoes are provided as well as fried potatoes. And here we see one of the less healthy sweets. So the whole element of the competition was to provide choices, but with the emphasis on providing healthy choices.
Outside the health authorities, we already have a trend of dietitians working in the food industry and freelance journalism, the media, and also dietitians setting up in private practice. And I think all these three areas will expand considerably in the future.
Well, I work as the senior nutritionist at Tesco's with another nutritionist, providing nutrition information on all our own label products, which ranges, it varies. We launch about 1,000 a year. At current, we have about 3,000. Another part of the job is providing educational material on nutrition to customers. And we really seek inspiration from informed sources on what sort of topics to cover, and also the customers themselves. They know what they're confused about, they write in.
Providing nutrition information is vital.
I run the Nutrition and Health Programme within the Information Department of the National Dairy Council. And together with a colleague, we have two major functions. One is providing information for the public, for health professionals, for the industry, the media. And the other one is actually producing material. What we're trying to do really is to provide information on the nutritional value of milk, why it's a good food, and to set it in perspective to show how it can be part of a healthy, balanced diet, and this is by providing recipes, by providing leaflets. But obviously we're also responding to consumer wishes, and one of the successful initiatives over the last few years is the education programme associated with the bottle tops, showing what bottle top identifies: skim milk, semi-skim milk, whole milk. There's a tremendous interest at the moment in healthy eating, and it's very important that the industry has somebody who can give sound expert advice, and who better to do it than a dietitian. I mean, I think it's a responsible attitude of the industry to employ people like dietitians.
Well, I've been appointed to advise, on the one hand, the meat industry, and on the other, opinion formers such as doctors, dietitians, health visitors, teachers, the media, about the nutritional value of meat and its role in a healthy diet. It is important to tell people that meat can be part of a healthy diet because it's not as fat as many people think. The Meat and Livestock Commission is a government body in that it's set up by statute, although it is in fact financed by the meat industry. And we do have a role to consumers as well as the meat industry. So it's important that we take into account what consumers are feeling at the moment, and there's no doubt that at the moment consumers want leaner meat and they want to know about the nutritional value of meat.
Giving people information is one thing, but can it always be used effectively?
Well, I worked for 7 years as a community dietitian in Lambeth, in a sort of very deprived inner city area. Spent a lot of time talking with pensioners group, mothers and toddlers groups, all sorts of people about food and nutrition. Everybody I came across was really interested, wanted to know more. But the number of times people actually said to me, okay, that's all very well, but I can't afford it, or I can't buy it. At one point, I actually wrote a list of the shops selling wholemeal bread. This was a few years back. And in a whole area of Lambeth, there were 4 shops where you could buy wholemeal bread. And then, even now, the price is 10p a loaf more. And I just felt, it's okay me giving all these people information and then the government saying, you've got this information, now look after yourself. But actually, a lot of people don't have the money, don't have the facilities to cook, don't have the knowledge about cooking skills, and also don't have the information about the food we're eating. So I actually found that quite frustrating. And when the job with the London Food Commission came up, I saw that as an opportunity to sort of take one step back and say, okay, this is the advice we're giving people. There are all sorts of constraints about why, for no fault of their own, they can't put that into advice. Let's challenge some of those things and tackle the food industry and the government and put them on the spot and say, why aren't you doing this? Why are you producing food with all these things? Why is wholemeal bread 10 pence more than white bread? What are you going to do about it? And that's the sort of work that the London Food Commission does now.
How do national policies evolve?
Liaison with other professionals is extremely important. I think as far as policy development is concerned, we depend very much on interagency collaboration. And certainly I, as the nutritionist at the Health Education Authority, would look very much to the British Dietetic Association as the professional body which should give authoritative information on nutrition.
Medical research influences nutrition.
Many of the patients that I see may have diseases that are directly related to their diet. For example, they could have diabetes or a high blood cholesterol, or they may simply be obese. And in these patients, the advice and the cooperation of the dietitian is an essential part of their management and treatment. But even if the diseases are not directly related to their diet, we may need the dietitian's specialist help. For example, if a patient is very sick or on the intensive care unit, not able to eat, they need to have parenteral nutrition. They may need very, very high calorie intakes. After surgery, a sick patient eats calories, and yet our patients have a very restricted fluid load. So you have to get a very careful balance between the volume you can give and the amount of calories you pack in. Now that takes a diet that must be worked out for each individual patient. But there's another way in which any major centre would need to work with a dietitian that's perhaps less obvious, and that is that all the major teaching centres carry out a very active programme of clinical research. That is, we may try to find out in normal people or in patients who volunteer what it is about aspects of their diet and their nutrition that cause the disease or cause a complication. We may need, for example, to study the salt intake of a patient with heart failure, and this would need a very tightly controlled diet with a fixed amount of salt for that person, and without the help of the dietitian, we simply couldn't do this form of research at all.
Preventative medicine can include screening at-risk groups and may reduce the number of hospital admissions.
I work at the Radcliffe Infirmary in Oxford. I'm the chief dietitian there, but every Monday morning I go to the John Radcliffe Hospital to do the lipid clinic, to cover for the lipid clinic, and I'm their nutritional advisor.
Now, you've just put a sample of blood into the Replicon, Jane. What is this instrument going to be able to measure?
It can measure both cholesterols and triglycerides, and it's used as a screening machine. Cholesterol itself in the diet doesn't necessarily raise blood cholesterols to any great extent, but rather the saturated fat in your diet raises blood cholesterol.
So we're looking for a measurement of serum cholesterol rather than cholesterol which is in the food that a person might be eating.
Correct.
So to begin with, I think what would be helpful is if I can run through with you what you would eat on a typical day, and then after that I can give you some advice on how you can change your eating habits to help control your diabetes.
How do you feel about it now?
In the past, diabetics have had to attend a hospital clinic to see the diabetic consultant. Here we can provide more regular advice in an environment where they live locally, that they know. At the hospital, in the hospital situation, we did tend to have quite a high DNA rate, particularly from patients living in this particular area, as it was such a long journey to the hospital, whereas here we have more regular contact with them.
But there'll always be some patients who need a hospital dietitian.
I'm Dr. Griffin. This is the nutrition team, and we've been asked to come and see you about your nutritional support now that you've come into hospital. I understand that Jill has been seeing you, and Jill, I wonder if you could tell us what's been happening in the last few weeks.
Yep, sure. I first saw Jane about 18 months ago when she was first referred when she had first symptoms of diarrhoea. We tried a high-fibre diet. It was thought that she had irritable bowel syndrome or ulcerative colitis then. I think you were on that for about 3 or 4 weeks, Jane, weren't you? And your symptoms got worse. So we stopped that and tried a low-residue diet to see if that would bring on some improvement. Again, that didn't really improve the situation. And then about a month later, we tried a lactose-free diet.
which I think you've been following ever since, but your symptoms over the last few weeks have got worse. The aim of a nutrition team is to rationalise the nutritional support services within a hospital. The team usually consists of a consultant, a dietitian, a pharmacist, usually a representative from chemical pathology, and generally a sister who's usually concerned with infection control.
However small the person, the right diet can save life.
She's still on parenteral nutrition and she's still taking a small amount of comminuted chicken. We're going to keep her on 30% of comminuted chicken, which is actual full strength of the chicks itself. We're keeping the carbohydrate, the maxidule, at 10%, but we're increasing the collagen today to 12%, which is a 6% fat mixture in total. I'm a paediatric dietitian. I work at Birmingham Children's Hospital. I've got a fairly unique job. I work with sick infants and children, and I think dietitians have an essential role to play in the management of sick children. Infants and children are growing extremely rapidly. Because of this, their nutritional requirements are extremely high. We have particular problems when medical problems either impair their appetites or increase their nutritional requirements. And so as a paediatric dietitian, I've got to make sure we get these little ones to grow properly. A paediatrician probably gets only a small handful of lectures on paediatric nutrition in his training, whereas we spend many years learning the art and the technique. I wanted to do something in the health field, but I didn't quite see myself as a nurse. I wanted to do something in close liaison with patients, and I've certainly got this. I wouldn't do any other job at all.
State-registered dietitians play a vital role in the care of patients in our hospitals and as advisors in the community. A dietitian is needed by the young and the old, and those with special dietary needs. With research constantly looking at what and why we eat certain foods, the profession is becoming increasingly involved in such areas as recreation, sport and industry. The dietitian has to be an essential ingredient in the recipe for health.